Hey guys, today let's talk about vocal fold palsy. So before that, we need to know about the nerve supply and the other basics of larynx. So the nerve which innervates the larynx, it's the vagus nerve, cranial nerve 10th. It exits the brain stem and has a complex root. It innervates many organs in the wide range, and larynx is one of them. As it descends, it gives two branches to supply to innervate the larynx, which are superior laryngeal nerve and the recurrent laryngeal nerve. Superior laryngeal nerve gives off two branches again. These are external laryngeal nerve and the internal laryngeal nerve. Larynx is divided into three parts: supraglottis, glottis, and subglottis. The glottis is the part in which we have the vocal cords. Above than that, we have supraglottis. Every part which comes above than the vocal cord, that comes under the supraglottis, and every part of the larynx, every structure of the larynx which comes under the vocal cords, that's the part of subglottis. Superior laryngeal nerve supplies the supraglottis and some superior part of the glottis. And recurrent laryngeal nerve supplies the subglottis and some part of the glottis, which is the lower part. So this can be dividing. So the above part is supplied by the superior laryngeal nerve, and the below this line is supplied by the recurrent laryngeal nerve. And now about the muscles. So only one and only muscle, which is cricothyroid muscle, is innervated by the superior laryngeal nerve. Other than that, all the muscles of the larynx are innervated by the recurrent laryngeal nerve. This was a very important note. Before getting into the pathologies, we need to know some positions of the vocal cord, and these should be into your mind to know the pathologies. So actually, if the vocal cord is in the middle, say this one, so if it's just in the middle, this position is called median position of the vocal cord. Just slight abduction would be called as paramedian. Next to that is cadaveric, or it could be also called as intermediate. Next to that, it's slight abduction, and this one is full abduction. So, just one more thing to keep into your mind, that is to produce voice, the vocal folds need to be closer to each other. So, this is the position of vocal cords whenever we need phonation. But whenever the person is breathing, in that case, they should be away from each other, because for the inspiration, they need to pass the air from it. So, this is the position for inspiration. Talking about the muscles of the larynx, so the only cricothyroid muscle is there, which is supplied by the superior laryngeal nerve, and that is an adductor muscle, that is bringing the vocal cords together to near to each other, to close to each other. Yeah, and other muscles are also there which are working as an adductors, but these are supplied by recurrent laryngeal nerves. Okay, and all the abductor muscles are supplied by the recurrent laryngeal nerve. So this thing you should keep in mind, and let's get into the pathologies now. Let's take two pulses together. These are unilateral and bilateral SLN pulses. So now you know that SLN is supplying only the cricothyroid muscle out of all the muscles of larynx, right? And this cricothyroid is, you know that it's an adductor muscle, so it's bringing the vocal cords together. Yes, but if let's say in the unilateral and bilateral SLN pulses, this cricothyroid muscle won't be working. So this adductor muscle is not working, but other adductor muscles are working. These adductor muscles are working, and abductor muscles are also working. So they are equalizing each other, kind of equalizing each other, but not properly. But still, they are good. So these are the pulses. These both they can easily go unnoticed, because patient will not have any severe symptom. Just one problem would be there, the problem in the production of high pitched voice. This would be more severe in the bilateral SLN palsy, but it will be milder in the unilateral SLN palsy. No other symptoms, no severe voice hoarseness or something. So that's why it can easily go unnoticed. Actually, more specifically, we should call it ELN, because ELN is the one which is supplying the cricothyroid. Okay, but if bilateral SLN palsy, it means both branches of the SLN, the superior laryngeal nerve palsy, is there. In that case, one symptom should also be there, which is absence of cuff reflex. and due to that, the aspiration is very common in the bilateral SLN palsies. Now, the unilateral RLN palsy, recurrent laryngeal nerve palsy, if it's unilaterally injured, in that case, what is not working? These adductor muscles and all of the abductor muscles, these are not working. It means the only one muscle is working, which is cricothyroid, and that is an adductor muscle. So the final movement of the vocal cord, the unilateral one-sided vocal cord, would be inside, yes, and the position should be, in this case, position is paramedian. Why paramedian? Why not median? Because other adductor muscles are not working, so it's not properly adducted. So due to this, just one muscle, cricothyroid, the position would be paramedian. In this case, we will not have any problem with the airways, but we'll be having the problem with the phonation. Now, what will happen? Compensatory hypertrophy of other vocal cord will occur in few weeks and months. So let's say this the position of unilateral vocal cord is paramedian, and the other vocal cord will get hypertrophied, and it will be just covering up this space. So there will be voice improvement in some weeks to months. Now, if the injury occurs in the unilateral RLN and unilateral ELN, what will happen? See, if the unilateral RLN injury occurs, it means all the adductors muscles are gone, all the abductor muscles are gone, and due to unilateral ELN injury, this cricothyroid is also gone. It means now no one is adducting and no one is abducting, no one is pulling, no one is pushing. So the position of this vocal cord, this unilateral vocal cord, should be intermediate, in between. Yes, and that is the cadaveric position, this one. Okay. In this case, there will be no problem in the breathing, but voice will also not improve in this case, as it was improving in the unilateral RLN injury due to hypertrophy. In this case, it will not improve. Now, the bilateral RLN palsy. If RLN is gone, it means the adductor muscles are gone, abductor muscles are gone in the both sides. Yes, this one and this one, everything is gone. Just one muscle will be left, which is cricothyroid, which is supplied by the SLN. Now, only adductor muscle is left. It means the vocal cords will be coming nearer to each other. Yes, but not in the median position, because all adductor muscles are not present here. Only cricothyroid is left. That's why the bilateral position would be paramedian position in both sides. So they will come closer. And now you know that in this case, phonation would be good, because we need the closure of the vocal cord. As I told you, we need the vocal cords to be nearer to each other for the voice production, for the phonation. But for the breathing, we need them to get away, yes, to pass the breathe to for the inspiration. That's why in this case, patient will have biphasic stridor as a reason. The reason would be the paramedian position of the vocal cords. Only 2 to 3 airway will be left there to breathe, and that's why the patient will have the stridor.